Breaking online platform, SICOT's pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Looking good.
Okay. Good morning, everybody, or good evening, wherever you are. We're truly excited to be here today. We have a truly international ulnar wrist pain webinar. My name's SANJEEV KAKAR, and I'm honored to moderate today's session with my good friend TOSHI NAKAMURA. We truly have an international theme today coming from all over the globe, and really want to thank SICOT and ISAKOS for co-sponsoring and branding this event. You'll see we have an ambitious agenda, trying to go through the myriad of different topics in ulnar wrist pain in an hour. So without any further ado, I'd like to kick it off to Dr. Margaret Fock, who will give us an outline of how she works up ulnar-sided wrist pain. So over to you, Dr. Fock.
Thank you, Sanj. So, thank you. So, I'm going to talk to you, yes, about the workup on the wrist pain. So, as we all know, ulnar wrist pain is very common. We have pain of movement, pain of rotation. It may be associated with sense of instability and sense of tingling sensation. But not everything is about TFCC. Because if you look at the wrist anatomy, you can see that there's a lot more things than the TFCC or the DRUJ. There's all the carpal bones, there's ulnar neurovascular injuries, and the tendons. So basically, if you look at the list of ulnar wrist pain, it can be like TFCC tear. It can also be the ulnar styloid fracture or non-union, ulnar impaction syndrome, Kinbox disease. Then you've got the ECU, tendinitis or subluxation. Then you've got all the other carpal fractures or instability. And you also have the mid-carpal instability or the ulnar nerve entrapment or ulnar artery thrombosis. So how should we work it out? So we should first do the history. History is always important. And that includes what we should take into account about the hand dominance, the previous medical history in terms of previous injuries or procedure, the social history like occupation or what they do for fun. Then we need to ask about the traumatic injuries as well as the time course. For example, whether it's a sudden onset or whether it's a gradual onset and whether it's acute versus chronic. Also, we need to ask about the associated symptoms in terms of paresthesia or numbness. what kind of precipitating factors or relieving factors, or the radiation of pain, is it from the elbow downwards, and any swelling, erythema, or tenderness, any presence of deformity or instability, and what kind of therapy they have done, including injections. Of course, last but not least, we have to think about the workers' compensation. So physical examination, we started off, of course, like any orthopedic examination, we started off inspection. We look for the symmetry of the wrist and hand. We look for any atrophy, any the skin conditions, any scar or deformity like claw hand deformity. Then we do the palpation in terms of the osseous and joint tenderness. And then we look at the tendons and mass. Then we go on the range of movement, and last but not least, the provocative maneuver, which includes like allotment, energy test. And if needed, if we think it is a neurovascular injuries or pathology, then we need to check the vascular or neurological. But one thing that's very, very important is create your own system and follow it every single time. Because if that's the case, then you will not miss anything. So that is how I would do it. I will first palpate all the tenderness of the bony structure and the joint. Then I will go and I start with dorsal first. I do radial to ulnar, distal to proximal before I go on the volar. If I think that it's a DRUJ ulnar wrist pain, then I will do the ulnar foveal test, which there is a good sensitivity and specificity. We do the DRUJ allotment. Then we worry about whether there's any ulnar compression test, which we notice that it is specific for ulnar pathology for 100%, as NAKAMURA was saying. Then we can do press test, ECU instability, and synergy tests for the ECU tendinitis. So these are some of the tests that we do. For example, it's a allotment test that we try to see the piano sign that you can see whether there is the RUJ instability. You do the ulnar compression test, or you can ask the patients to push themselves out of a chair, which is the press test. You can do the synergy test for ECU tendinitis, or you can feel for ECU subluxation during the forearm rotation. If you think there's more of a carpal bone problems like LT, then you can do the ulnar allotment test or the Kim-Shark test. For the PT, for the peripheral tricuspid arthritis, then you can do the PT shearing test or FCU test. Then you can charge for mid-carpal instability. And if you think there is a hook of handmade tenderness, then you really need to do and examine the ulnar nerve as well. So ulnar neurological vascular test is only needed if it's indicated. So this is how you do the allotment test for the LT or the PT, basically grabbing the pisiform and trying to grind it with the tricuspid, and you can do the mid-carpal instability test and try to push it up. Then after that, everything, then we go for investigation in terms of X-ray, ultrasound, CT, and MRI, or with or without arthrogram, that depending on what you find in history and physical examination. Last but not least, we may go into diagnostic tests in terms of injection or wrist arthroscopy if needed. X-ray, what do we need? Well, if we think there's a bony pathology, we can from the X-ray AP, we can see the ulnar variance, the ulnar styloid head fracture, the RUJ arthritis or subluxation, or even lunar malacia, in ulnar impaction syndrome. We can see in X-ray whether there's any Kinloch's disease or LT instability with the deformity. So with chronic instability and they have a really big instability, you can see that the lunar go in the turn into dorsal. We also have special views for fractures, if that's what we worry about, or arthritis. For example, for the tricuspid, the hook of M8, we have carpal tunnel view at dorsiflexion with the wrist dorsiflexion 30 degrees, or the PT arthritis, which is a reverse oblique view of the 30 degrees supination. For if it's more of a soft tissue, then we can use ultrasound because it's a dynamic test which will look at the tendon subluxation or tenosynovitis, or we can see a mass or nerve entrapment because we can see the nerve and we can follow the nerve to see the shape of the nerve changes or any extrinsic space occupying lesion. We can also do the Doppler when we do the ultrasound to see if we think that it is more of a vascular problem. CT is obviously a better delineation of the osseous structures, and MRI Of course, we do it for the TFCC or ulnar infection when for early lunar malacia, which you may not see it in X-ray. You can also see a tendon condition, but this is now not dynamic. You can see the inflammation and integrity, and you see the cartilage status. I think nowadays the MRI is very good with 3.0, and when they said that they compare with the previous 1.5T, it shows better sensitivity and specificity in TFCC injuries. So do we really need arthrogram? Well, yes and no. Sometimes it's difficult because arthrogram do create a little bit more discomfort for the patients, and also is an additional procedure. So in conclusion, ulnar wrist pain is definitely common. There's many causes. It's not just DRUJ or TFCC. History is always the most important thing. That is followed by doing a clinical examination and to confirm the diagnosis and actually eliminate some of your differential diagnosis. But remember to create your own routine. You should do the investigation to confirm what your diagnosis is, and if needed, then you can do arthroscopy injection. So with that, thank you for listening, and hope to see you in Hong Kong sometime. Thank you.
Thank you, Margaret. That was a wonderful overview, and really appreciated the pearls that you shared with there. It's a very exhaustive topic, but you set up nicely now for the rest of the webinar. And joining us next needs no introduction, TOSHI Nakamura, who will be teaching us about the anatomy of the TFCC. TOSHI?
Can you hear me?
Yes, we can hear you, TOSHI. Can't see your slides.
I can't see that. Okay, let's start. How about this one?
Yes, we can see it.
Yeah, my talk is anatomy of the triangular fibrocartilage complex. So I'm thank you for the Margaret that mostly talked about the physical examination, and also that anatomical knowledge of the TFCC region is quite important to treat an ulnar side wrist pain patients. So TFCC was firstly reported by Andy Permer in 1981. Then there are several components in this structure. Then everyone agreed with the function of the structure is a stabilizer of the ulnar carpal and DRUJ, load distributed between ulnar and ulnar corpus, and it allows with smooth motion, including a forearm prospination. But most important function of the structure is a DRUJ stabilizer. So this is the primary stabilizer of the DRUJ. Then in early 1990s, then when I actually started the research job, then everybody considered the TFCC is a triangular shape, disc shape, which is a two-dimensional structure. But obviously, this is a three-dimensional structure. So when I did an anatomical study in 1996, then I found that the distal portion of the TFCC is more like a hammock-like structure, which can surround and support an ulnar corpus. So you can see disc region. Then you also see the central region. You can see ulnar head. And then DRUJ is much more proximal from the radiocarpal joint surface. Then the very ulnar side of the TFCC, you can see a ECUC floor. Then when I cut the capsule of the DRUJ, then ulnar head is turned over. There is the obvious radioulnar ligament coming from the foveal region to the distal portion of the sigmoid notch. You can see a robust fiber of the radioulnar ligament. Then the histological findings showing that the radioulnar ligament can be arose from the nearly vertical structure from the foveal region. Then that is actually rotation axis passes to the foveal region. Then the radioulnar ligament is much more easy twisting structure during prospination, while triangular fibrocartilage faces to the lunate and tricketum, which is a supporter of the ulnar corpus. There is a variation of the specimens, but however, the most important part is the foveal region, always that the ligament fibers arose from the nearly vertical. So that can actually help to easy rotation, forearm rotation. So TFCC is a stabilizer. Triangular fibrocartilage is a stabilizer of the ulnar corpus, and then the radioulnar ligament is the primary stabilizer of the DRUJ. It has a vertical origin, and TFCC is a fibrocartilaginous area. Then a higher magnification of the histology findings that there is sharpy fibers as a fovea. So this is obviously the ligament. While the tip of the ulnar styloid, you can see a hyaline-like cartilage. So this connection of the TFCC to the tip of the ulnar styloid is much more weaker. So when you see a fracture of the ulnar styloid, tip of the ulnar styloid, that can be impaction of the ulnar styloid to the trichetrum, not the avulsion. While the radial side, you can see in the central region, there is a transition of the cartilage to fibers as the central region of the radial TFC, while very dorsal and very palmar side, you can see obviously the sharpy fibers at the very dorsal edge and very palmar edge of the sigmoid notch. So this dorsal side and very palmar side, there is a ligament. So this is a three-dimensional structure of the TFCC, which was published in 1996. Then TFCC is a hammock-like shape. Then radioulnar ligament was attaching to the foveal region nearly vertical, with a nearly vertical insertion, which was already described by a Kaplan's textbook. DRUJ, this is a quite unique joint. And actually, radius of the sigmoid notch and radius of the ulnar head is quite different. So this is actually stable but unstable joint. So normally there is some translation arrows inside the joint. Then normally that the radius rotate around the 135 degrees with respect to the ulnar head. There are several factors of the DRUJ stabilization. A static fiber is joint congruity. Then the most important soft tissue strength is radioulnar ligament. Then distal interosseous membrane was reported by Moritomo, was actually secondary stabilizer. Then axis of rotation is the static factors. Then also that there are dynamic factors including the muscle pronators, spinators, or direction of the motion of pronating or spinating. Actually, there is incongruity with the DRUJ. Then when in the pronation, ulnar head goes to dorsal, then in spination, ulnar head goes palmar. Then early 90s, we are going to have a Schwind-Eckenstein paradox, which is a very famous paradox. And Schwind from Mayo Clinic described that dorsal portion was stretching pronation, the palmar portion was stretching spination. Eckenstein and Haggard describes the completely opposite. Dorsal was stretching spination and palmar was stretching pronation. But those paradoxes coming from two-dimensional ideas. So you can see just a two-dimensional ideas. But the fact is that the TFC is a three-dimensional structure. Then Kleiman later describes that the superficial portion and deep portion. Then deep part is quite important, which is correspond to my radioulnar ligament. Then actually I did an also biomechanical study, which was the length pattern of the radioulnar ligament with the three-dimensional shape of the TFCC remained intact. Then I actually measured the length change pattern of the radioulnar ligament. Then two specimens showing that the palmar portion was stretching spination, the dorsal portion was stretching pronation, same as the Schwind report. While that some specimen, two specimens showing the palmar portion is quite isometric. Then in these specimens, the main fibers was attaching to the central region of the fovea. Then two specimens showing the dorsal is nearly isometric, then the dorsal portion is dominant, then attaching to the more central side of the fovea region. Then those are actually fovea central attaching fibers are showing that the nearly isometric pattern, then eccentric fibers showing that dorsal fiber longer in pronation, the palmar fiber longer in spination. So this suggests that when the radioulnar ligament is repaired or reconstructed or reattached to the fovea, it must be reattached to the central region as possible to the fovea, where the rotation axis passes and where is the isometric point. Now you can see how to repair the TFC. TFC is again the stabilizer of the DRUJ, then the radioulnar ligament was vertical origin. Once then When the foveal region was avulsed, DRUJ showing that the severe DRUJ instability. However, the scopic findings from the radiocarpal joint or surface, you cannot see a foveal region if there is no tear on the TFC. So that is why that we need a DRUJ scope. This is the DRUJ scope findings that you can see, and very beautiful, showing the ulnar head. Then you can also see robust fibers of the origin of the radioulnar ligament, and those are portion and palmar portion. Treatment of the TFCC region with conservative treatment or operation, and mostly was the repair of the TFCC, open arthroscopic or reconstruction. Then maybe later the next speakers can talk about this kind of treatment. So this is my take-home message. TFC is a hammock, then which has an anchor to the foveal region. When the foveal region was anchor was ruptured, then TFC was unstable. This is the DRUJ instability. Then you can repair or reconstruct it. Thank you for your attention.
Thank you, Toshi, and I'm glad that you can put yourself in the cartoon there in the hammock. That was a wonderful overview of the anatomy, and that really has been the foundation for a lot of what we do in 2024. So with that set up, I'd like to invite Andrew Chin to talk about repair of those peripheral fibers of the TFCC. Andrew.
Thank you very much.
And you enter into the 6-hour portal.
Oops, sorry. All right, thank you very much. Sorry for the delay. And I would like to go straight into my topic, which is the peripheral repair of the TFCC. There's no disclosure for me. And just want to briefly state the importance of this TFCC, which Toshi has succinctly put it, being a soft tissue stabilizer.
Andrew, you're on mute.
Okay.
That's better. Thank you.
Can you hear me?
Yeah.
Yeah. So it's a soft tissue stabilizer of the distal radial ulnar joint, as well as the ulnar carpal joint. It prevents a subluxation of DRUJ and facilitates a smooth gliding motion during forearm rotation. And it's also a shock absorber, as Toshi has succinctly put it. All right, so in 1989, Palmer has classified the TFCC injuries into two classes. One is that of the traumatic, which is what we are interested in today, as well as the degenerative, which we will not be talking about, right? And I'd say in 2009 has come up with this classification, which is actually adopted by EWAS, to actually treat this TFCC tears. And in particular, class 1, which we are looking at, which is for us to be able to treat 1B tears based on the Palmer classification, which is actually the peripheral tears over the ulnar aspect. And he has correlated the treatment option with this classification, and most of them actually are repairable. In fact, all of them are repairable if the tears are based on this classification. Briefly on management of peripheral tears. Usually the first line is conservative. We tend to give the patient some medications, pain relief, because it's one of the commonest pain generators of the ulnar-sided wrist pain. And of course, we have other adjuncts like corticosteroid injections, as well as immobilization, usually with a Munster type of splint, to sort of secure the patient in neutral position without risk of excessive pronosupination. Some actually do have successful outcomes. based on the nature's way of healing, especially in those with partial injuries. So for the management of surgical management of peripheral tears, mainly for the traumatic ones, arthroscopy still remains the gold standard for diagnosis and also for therapeutic management. In 1A tears, usually a debridement is done. For 1B and 1C, it can be repaired. This is of our interest. For the 1E, unfortunately, because of the lack of blood supply, they are usually non-repairable. And what's the rationale for treatment? As I mentioned earlier on, blood supply is the main thing. You can see from this experiment and with all the dye injections, you can see the vascularity of a TFCC is very, very rich over the periphery and the ulnar aspect. But there's a paucity of blood supply to the central areas as well as the radial attachment. So sometimes it's if you have a tear over the central aspect or perforation, there's nothing you can do about it because it's not going to heal whatever you do. So thankfully, the peripheral tears are in the area where there's a rich blood supply, which is why these areas are of interest because they are actually amenable to therapeutic options. Okay, so what are the indications? Open injuries or concomitant acute surgical treatment of other injuries such as ulnar styloid fractures and of course other injuries around the wrist. A field conservative management for closed injuries, right? After failure for weeks or even up to a few months, sometimes the patients come to you in the clinic, and lo and behold, once you have diagnosed based on what Margaret has shown us, right? So these are actually indications that the patient will require some form of surgical management. Type 1Bs and Cs based on Palmer classification and usually a diagnosis on arthroscopy, right? And for type 1B tears, usually the class 1, 2, or 3 based on the ATSES-EWAS classification. And for peripheral tears, they are usually class 1 based on, again, ATSES-EWAS classification. And these are the ones that we are looking at based on this talk. So for peripheral tears, usually does not severely affect the DRUJ stability, right? And they are usually along or close to the edge of the volar and the dorsal DRUL. And they're usually class 1 or type 1B tears at the styloid attachment. So what are the various treatment techniques that we have described so far in literature? Open technique is not commonly done nowadays. It's in occasional situations where there is no arthroscope and where there's no one who is adequately trained in arthroscopy, then open surgery is probably the only option available. Otherwise, most centers around the world now embrace arthroscopic or arthroscopic-assisted form of repair. And this is the main technique for such a peripheral repair. And it's based on suture knot placement. Either is it an outside-in technique, inside-out, or inside, or the one using specialized kit like this one by Smith and Nephew. So the outside-in, and there are also a few variations, and Hogsved from Norway and his colleagues have actually published and succinctly described their technique of outside in, and this is a very instructional kind of a paper that you can actually read based on these references given. Of course, you also have the inside out and all inside technique, which are described again by other eminent wrist experts from around the world. And indeed, these are various techniques that we can actually train ourselves to be experts in, and also to provide treatment options for our patients. And of course, using specialized kits, we can also use this like ultrasonic welding machines that we can use to help us to repair the peripheral tears. Okay, in the interest of time, I shall not go through the video, but essentially in detail.
Peripheral repair.
There are many
1B
educational videos that are available on YouTube and other platforms that can actually help us to
is retracted, and here's a needle brought in through the floor of the ECU through the peripheral tear itself.
So we prefer actually dry arthroscopy. So actually sometimes we are doing all these dry arthroscopes to help us to have a better visualization and also to be able to do a proper repair of the TFCC, like this lab demonstration that I did recently.
Twist the needle so
in
that
interest of time, I shall just move on to the conclusion. All right, peripheral tears of TFCC is one of the most common generators of ulnar-sided wrist pain. Isolated peripheral tears usually do not affect DRUJ stability. Classifications have evolved, and now we are using the ATSE-IWAS classification to provide some sort of a group correlation to treatment options as well as outcome. And due to the adequate blood supply of the periphery, such tears can usually heal, and they're usually repairable. Repairs are using arthroscopy as a main modality of surgical treatment nowadays, and different techniques described have been published, and there's no one superior technique over the other. With this, I thank you. Hope to see you in Belgrade.
That was a wonderful review of the peripheral repairs. My task now is to share with you foveal repairs that Andrew kindly set us up for regarding the peripheral repairs. So just share this. Okay, so in terms of the foveal repairs, as Toshi mentioned, these are those tears that lie underneath the superficial portion of the TFCC. And some of the videos, in the interest of time, we won't have a lot of time to go through. But if you look at this QR code, they're part of Handy, which is a digital platform from the American Society for Surgery, the H. So we have three key takeaways from when managing ulnar-sided wrist pain. As we heard from Dr. Fock, the clinic history and physical exam is 90 to 95% of this. And I think one of the keys is how we interpret our own MRIs. And so we'll go through that. And also, as Dr. Nakamura mentioned, the power of DRUJ arthroscopy. I'm not going to labor the soft tissue anatomy, as Dr. Nakamura has taught us all about this. But the key thing is that he mentioned is that the foveal insertion of the TFCC is critical in terms of being a static stabilizer for the DRUJ. And when you scope a wrist and you put the camera in the radiocarpal joint, unless there's a concomitant central tear, you're looking at the superficial fibers. And so really, unless you're doing a DRUJ arthroscopy and looking at this, everything is an indirect assessment of the foveal attachment of the TFCC. We heard of the importance of the fovea sign described by Dr. Berger. And to me, this is a highly sensitive and specific test for essentially TFCC or ulnar triquetral split tear pathology. And so going into the operating room, I have that in my mind, and I deduce the diagnosis based on the arthroscopic findings. Many people get MRIs, but how useful is it? Well, it's been shown it's useful for central, but not peripheral tears, and these are the tears that we're after today. This is a nice article by Eamon and colleagues, and basically it's looking at the axial view of the DRUJ, and on the left, you'll see if you draw a line along the dorsal aspect of the radius, the distal ulnar should sit volar to this. On the right, you'll see that there's a foveal injury. And so if there's dorsal subluxation to this line, that should be a clue to you that there may be foveal pathology. We heard about the important classification by Dr. Palmer and Andrea Atzi and Riccardo Lucchetti. And what we're talking about are these type 3 tears where you have the foveal injury with or without superficial fiber derangement. And so how do you test foveal attachments in the operating room? Well, essentially, there's 4 key arthroscopic tests. So the hook test, so the camera is in the 3-4 portal, and we're taking a probe and lifting this up through the 6R portal. And you can see that this is a highly positive hook test. Well, what about the trampoline test? There's a lot of subjectivity in these tests, as recently reported by Goldfarb. But here, what you're seeing is by pushing down on a probe, there's a natural buoyancy to the TFCC. So to me, this was a normal trampoline test. What about the suction test? So here we're turning the suction on, and you can see that this clearly lifts off the TFCC. So this gives you an idea of the diagnosis, but also you can use the suction test to see how much stability do you need to put when you're putting sutures in. So here you'll see I put 2 peripheral sutures, but it's still lifted up. And so we had to put a larger suture to give us natural buoyancy of the TFCC. And then finally, as we heard earlier on about DRUJ arthroscopy, and there's a wonderful article by Dr. Ecker teaching us how to do this. But essentially, the easy way to do this is that you have the camera in the 3-4 portal, and you put the needle underneath the TFCC. So here you can see the needle is underneath the TFCC. I wholeheartedly agree with Dr. Chin about doing this dry, because saline insufflation sometimes makes it a little bit harder for me to see. Now here we're using a switching stick technique. So now we know we're in the right place. We simply put the trocar in and you can have a direct view of the foveal attachment. So how do we put this into a clinical case? So here's a patient who had a nasty distal radius and distal ulnar fracture, was seen by a pediatric orthopedic colleagues, and I think they did a nice job in reducing and restoring the bony stability. And this is that patient 4 months later. I see him at 10 months later as he's noticed clunking with pronosupination, and you can clearly see an unstable DRUJ. So this is clearly unstable. When you look at the MRI, you can see that the foveal attachments, it's not as black, it's more gray, to me demonstrating scarring. And I'm telling you the importance of reading this yourself, because this was the read by the radiologist that the TFCC was intact and this was an ulnar triquetral split tear. Well, clearly that's not the case. There's something more going on here. And so putting this together, for me, this was a TFCC problem that we had to fix. So this patient had a negative trampoline sign and hook test. Here's we're making the DRUJ portal. And now here's the DRUJ arthroscopy. And as we come over to the ulnar side, so TFCC is above us and ulnar head is below us, you can see that TFCC is basically delaminated off the foveal insertion. So again, TFCC above, ulnar head below, we sweep to the ulnar side, and here you can see the foveal attachment is being delaminated. So here's the arthroscopic foveal repair. And then you don't need to wait for healing. You can see on the table, you've reduced the DRUJ and got immediate stability, and the patient's post-operative outcomes, he did well. So to me, this demonstrates that this TFCC on MRI may be structurally intact, but it's functionally incompetent. It's delaminated off its foveal insertion. And this can either be partial or complete. And this is a summary table giving you the arthroscopic findings and how to treat this. But the key takeaway that I want to leave you with is that not all foveal tears present with DRUJ instability. Here's an athlete that comes in with ulnar-sided wrist pain, tender in the fovea, tender in the ECU, was treated non-operatively, but had recalcitrant symptoms. Here's the MRI, and as Toshi mentioned, there should be a nice thick signal of the fovea going vertically. So to me, this was more of a partial injury, and you can see ECU subluxation. And I wholeheartedly agree, getting a dynamic ultrasound is sometimes helpful. So here, going into the operating room, we have to address not only the TFCC, but also the ECU. The mistake is addressing one without doing the other. These patients won't do well. So here's the trampoline test, and to me, this was equivocal. Okay, this was not grossly positive or negative. I would say this was equivocal. And I'm sure if I showed the panelists, we would all probably disagree what this is. Here's the hook test. So to me, again, this was probably a negative hook test. I put equivocal, being generous, but I thought it was negative. Here's the suction test. It lifts up, but TFCCs in general lift up. So to me, this was equivocal. But when we do the DRUJ scope, as we come now to the ulnar side, there's a partial tear of the foveal attachment to the TFCC. And so here now we've repaired the foveal attachment. There was also a UT split tear that we repaired at the same time. Don't forget to address the ECU. And so when we looked at our patients, now this is 24 patients with arthroscopically proven through the DRUJ of foveal injury. And the key takeaway is just under 80% had a stable DRUJ. So a fraction had unstable DRUJ instability despite having a foveal injury. And MRI was only accurate in about a third of cases in detecting this. The functional outcome scores had improved after surgery. The other key takeaway is out of the 24 patients, 19 had additional pathology that had to be addressed at the same time. So just don't address the fovea if they have other pathology going on. So the key finding is having a stable DRUJ exam and a normal MRI, if they're clinically symptomatic, does not rule out foveal injury. And so DRUJ arthroscopy is very powerful in these patients. Others have reported similar success rate with arthroscopic repairs. So again, in summary, the clinical exam and the history are 90 to 95% of this. But in the operating room, I think you have to have a myriad of different ways to test the TFCC and the foveal attachment to determine the repair. So thank you very much for that. And then moving on now, I'd like to welcome Professor ELKAREF from Egypt, who's going to be teaching us about the treatment for ulnar impaction.
Good afternoon, everybody. I will try to run a movie of my presentation, if you allow me.
Yes, please. Are you able to share that, Assam?
Yes.
I think if you hit play and then full screen mode, please.
Okay.
Did you turn the volume there, Assam? We can't hear it.
Okay, I'll try. This is the maximum, actually. If can Sophie turn it up from his side?
Sufyan, are you able to turn up the volume?
I think you should, if it doesn't play, you should activate share sound on your screen sharing option, Dr. ELKAREF.
Assam, are you able to stop sharing and then reshare and activate the optimized sound?
Okay. So I will go live with the presentation. Is this sound is better?
Yeah, that's great. That's perfect. Thank you. If you can do full share screen, that'd be great.
Okay. Okay, ulnar impaction syndrome is first described by Friedman and Palmer. It's the chronic degenerative pathology on the ulnar side of the wrist because of the positive ulnar variants that it usually lead to chronic degenerative pathologies as TFC tears, ulnar head articulation erosion, and leonated triquetrum articular cartilage, which is called the ulnocarpal chondromalacia. It may lead also to disruption of the leonotriquetral ligament, DRUJ instability, and osteoarthritis, and it may also lead to osteoarthritis of the wrist. We all aware with the biomechanical experimental study done by Palmer and published in 1986, where he said that 20% of the loads across the wrist is carried by the ulnocarpal articulation. And if the length of the ulna is decreased by 2.5 millimeter, the load will be transformed from 20% to 44.3%, while increasing in length of the ulna by 2.5 millimeter will increase the load across the ulnocarpal joint to 42%. And from this biomechanical study, the treatment of ulnar impaction syndrome evolved, aiming at restoring the ulnar variance to zero or negative ulnar variance. And actually, the two gold standard procedures used for treatment of ulnar impaction syndrome is the ulnar shortening osteotomy, first described by Milch in 1941, and the wafer procedure described by Filden in 1992. Both are the gold standard. However, despite the advance of the arthroscopy techniques and equipment, open wafer may have some place, and also the radial lengthening osteotomy may be justified for some cases. Cases with malunited fracture distal end of the radius will multiplane deformity more than shortening. It should be treated with addressing the radial side problem first in order to tightening the TFCC and its ligaments structures and the distal oblique band also in order to stabilize the DRUJ. While the cases with DRUJ osteoarthritis both procedures are contraindicated, as this needs salvage procedure rather than reconstructive surgery. According to the classic teaching, we have to try for early and mild cases, the conservative treatment in the form of non-steroidals, avoiding specific movement at axial loading, splint mobilization, steroid injection in some cases. However, in advanced cases of ulnar impaction syndrome, usually the conservative treatment is insufficient and surgery is more expected. Ulnar shortening osteotomy is an extra-articular procedure that preserves the capsules and ligaments around the joint. It is applied for many of the ulnar sided wrist problems, and it does mechanical decompression of the ulnocarpal joint by transferring the load to the radial side. It could be done in the diaphysis or the metaphysis of the ulna, transverse osteotomy, oblique osteotomy, step cut osteotomy, while the metaphyseal osteotomy, as described first by Slade 2007, have the advantage of preserving the cartilage, rapid healing, less hardware removal, rapid mobilization following surgery. But anyway, it is an intra-articular surgery. It is technically demanding, and there may be joint reaction force alteration. There is a biomechanical analysis of this distal metaphyseal osteotomy published in 2013, advocating that it is significantly decreasing the ulnar load, and dynamically the mean and maximum load has decreased, and there is no significant change transverse load across the DRUJ. The year after, by Joseph Hori, he again it's encouraging to do the distal metaphyseal osteotomy, mentioning the techniques and pearls of it. Diaphyseal osteotomy could be done distally or proximally. If we do it proximally, we will tighten the distal oblique band, the ligaments around the DRUJ and ulnar side of the wrist, adding to the stability of the DRUJ. But there is sometimes resistance to shortening, which is not there if we do it distally. Few papers have actually compared between the distal and diaphyseal and the metaphyseal ulnar shortening osteotomies. This is a recent paper, 2023, stating that there is a higher secondary procedure and higher rate of free fracture following the diaphyseal metacarpal osteotomy, diaphyseal ulnar shortening osteotomy. And this is another paper, also 2023, is stating that the metaphyseal osteotomy have the advantage of a short time of surgery and promoting early post-operative relief of pain and have a better rate of healing. On reviewing the literature, ulnar shortening osteotomy has a good outcome regarding the clinical improvement in grip strength, wrist functional scoring, distal ulnar articular surface has no damage. You can short whatever the length you have, 3 or 4, 5, 6 millimeters. It tightens the ulnocarpal ligaments and ulnar sided wrist structures, adding stability to the joint. But however, this procedure has been plagued with multiple complications, particularly delayed union, non-union in the old age, smokers, diabetics, hardware irritation, prolonged healing phase, long immobilization, increased demand to physiotherapy, psychological consequences, patient also reporting pain and cold intolerance, and some papers stating that the rate of non-union reached to 4% of the cases. Also, there may be a chance for malunion of the ulna with deformity affecting the morphology of the DRUJ that may lead to DRUJ arthritis. And there is also a risk of ulnar refracture following removal of the hardware. And this particularly in certain types of DRUJ with a special shape of the sigmoid notch. However, through the decades, there are many modifications to improve the results and make the ulnar shortening osteotomy more reliable.
Assam, can you wrap up, please, Assam?
Can you? Sorry.
Can you wrap up, please, and summarize? We have one more speaker, please.
Okay. So we have to avoid the ulnar shortening osteotomy in type 3 with reversed obliquity of the DRUJ, while the wafer procedure is a minimally invasive procedure with, again, good reputation in the literature. It yields satisfactory results. But again, have a potential risk as in a wrist arthroscopy. And we cannot do it if we need shortening more than 3 millimeter, as we will lose substantial amount of the ulnar head, which will affect the DRUJ and may lead to DRUJ arthritis. Actually, there are meta-analyses comparing both the wafer procedure and the ulnar shortening osteotomy, and they found that from the clinical point of view, both are the same, but there is a high rate of complications following ulnar shortening osteotomy. This is a recent paper published last month advocating for an algorithm for how to choose the proper procedure for ulnar impaction syndrome.
Thank you, Assam. I'm going to have to stop you there. Sorry, we're running out of time, and we have one more speaker. Thank you for that wonderful overview. Last but not least is Dr. BAIN, who's going to teach us about salvage procedures of the DRUJ. Greg, over to you.
Well, thanks very much, Sanj. Congratulations on this wonderful presentation and webinar session. These are my conflicts of interest, which I don't think are relevant to this presentation. So with regard to the salvage situation...
Can you share your screen there, Greg, please?
Sorry.
Thank you.
Of course. Can you see that now?
Yes, perfect. Thank you.
So this presentation is on salvage procedures of the distal radioulnar joint. These are my conflicts of interest, which I don't think are relevant to this presentation. When we're looking at the salvage options, I think it's really with instability, with a failed repair, and also for patients who've had procedures related to the distal radioulnar joint and maybe even rheumatoid arthritis. When we look at the ligament reconstructions that are being performed, it's usually for a failed arthroscopic repair. And we can see the technique that's popularized by Brian Adams. This is an anatomic position, or the foveal attachment, as Toshi's already told us, but the attachment onto the radius is not an anatomic or isometric position. When we look at the technique described by Shecker, I think this does reproduce the anatomical attachment points of the radioulnar ligament. So the indication for these type of procedures are chronic instability, and particularly those that have failed previous surgery. But one of my concerns about both these techniques is that this stabilizes the distal radioulnar joint, but part of the pathology of complex instability of the distal radioulnar joint is the carpal sag, where the whole carpus is sliding off from the distal ulnar as well, and that these techniques I've shown here are really not anatomical in stabilizing the carpus as well. The technique that we like to use is what we call a trans-ulnar stylet approach. So that's an incision through the ulnar side of the ulnar. We excise the ulnar stylet, which gives us a footprint right down to the fovea. And we are able to then put a drill hole through to the shaft of the ulnar. We're able to use like a shoulder anchor, so it's much larger, so we can get good stability of the anchor and of the triangular fibrocartilage. So we can see here, this is the palmaris longus graft, which has been weaved through the triangular fibrocartilage, and then that's placed into a shoulder anchor, and a similar technique is used for biceps tenodesis in the shoulder. We can then advance this anchor into the shaft of the ulnar, hammering it into position, creating this mattress-type suture to the triangular fibrocartilage. And we can see how that's held on and holding onto the proximal, to the distal ulnar, and we've got good stability of the anchor and of the triangular fibrocartilage complex. So we can see that this is really bowstring tight, which we'd never been able to achieve with other techniques. These other sutures can be used to stabilize the ECU subsheath. So going on to, for patients who have this type of very rounded volar sigmoid notch, we've been able to use this sigmoid notch osteoplasty, which is basically an osteotomy of the sigmoid notch, adding bone graft and K-wires to be able to reconstruct this volar lip, or a dorsal lip if required, of the distal radioulnar joint. There's lots of different techniques described for the patient who's had degenerative osteoarthritis or previous surgery of the distal ulnar, such as the Dara procedure, Suave-Kapanji procedure. We can even do a super Dara procedure, or if you've got this case here with Suave-Kapanji and a full wrist fusion, all of these case type of techniques have problems with impingement. And we all talk about the instability of the distal ulnar, but really probably the primary bone of the forearm is the ulnar. And as the radius under load with a weight, as taught to us by Lou Shecker, and then they rotate the forearm, they get this impingement and pinching pain. It's really uncomfortable for the patient. So all those techniques I've shown you still have this type of instability. And if we look at what's going on here, we've got the sigmoid notch, the volar cortex. This is what I call the KAKAR of the distal radius. And we can see as the forearm goes through rotation, how the ulnar is loading onto the sigmoid notch. We know the triangular fibrocartilage is providing stability for the whole concept, but this sigmoid notch and the KAKAR is a critical part of the mobilization of the wrist. So if we're going to do this type of construct, we're going to get instability. Dingman talks back many years ago, greater length. We get better stability, get the ulnar style carpus. Bowers and Watson taught us about the importance of a hemi-resection, but that we need to debride this distal ulnar styloid. And I'd like to acknowledge Jim Roth. When I was a fellow, I wrote this up for him. And this is the technique that he developed, going through the fifth extensor compartment, hemi-resection of the distal ulnar, debride that, make sure that this is rounded in the same shape as the distal radius so that it doesn't impinge. Suture from this conjoined capsule and extensor retinaculum, bring that down and stabilize the whole construct as seen here, and leaving the ECU sitting on the dorsal aspect of the distal ulnar to provide extra stability. I think it's important, and I still do this, place them in supination for 4 weeks to allow this whole soft tissue structure to stabilize. Going on just briefly about arthroplasty, we've found the Shecker prosthesis for these complex cases to be very valuable. This is a patient with 4 previous operations at 1 week. He's absolutely delighted. Another case here with revision arthroplasty. And finally, the other arthroplasty option is this ceramic Fernandez prosthesis underneath Suave-Kapanji, which is another alternative. Dean Satirianis taught us about this allograft, which is placed between the radius and the ulnar, and it's important that this is almost overstuffed to separate it, and that creates an indirect type of KAKAR between the radius and the ulnar, and we would only use that in complex cases of previous infection. And then the final thing, of course, is the one bone forearm. So in summary, firstly, thank you. It's important here to think about the KAKAR, to look at these options for revision cases, such as using a palmaris longus for the triangular fibrocartilage, hemi-resection, sigmoid notch osteoplasty, and even this crazy case here, we can see the Shecker prosthesis is able to get around the problems. For those of you interested in this topic, there's a paper we published in 2016 in the Asian Journal of Hand Surgery on distal radioulnar joint complications. Thank you very much for having me involved.
Thank you, Greg. Thank you, Greg. So that we thought that we're gonna have a discussion of the last part of this one, but we are actually running out of time at this moment. So that I would like to conclude that this webinar. Everybody actually talked about a very good overview for the ulnar side wrist pain, how to treat the patients, and arthroscopically or in a salvage or on a shortening. So I think that the audience actually have a good target to how to treat the TFCC or ulnar side wrist. So I'm going to conclude that this webinar. Then maybe that they're going to have some survey onto here. So if we have a survey, also that please let us know about the questions. Then we're going to try to answer to you all.
Thank you very much, everybody, and appreciate all your expertise and time. Thank you.
Thank you very much.
Nice job. Thank you. Thanks, SICOT. Thanks.